Welcome to today's program, a conversation around shared decision-making and a patient revolution and the role of the Pact Act, brought to you by the National Coalition for Cancer Survivorship. My name is Eric, and it will be my pleasure to be your moderator for today's session. For technical assistance, please send an email to canceradvocacy@compartners.com or send a message in the chat box. Today's program is scheduled for 90 minutes and includes 2 question and answer segments, one after each part of the webinar. Please note that today's session is being recorded and all participant lines will be muted during the session. If you need assistance at any time during the program, please select *0 and the operator will assist you. During our designated Q&A breaks at the end of the discussions, you may ask a question by selecting *1 on your telephone keypad or by typing your question in the chat box area located on the lower left corner of the screen. These instructions will be repeated later in the program. To interact with the presenters at any time, you may submit a question by using the chat feature located on the lower left side of your screen. Your questions will not be viewable by other attendees. If you look to the left of your screen, you will notice the links area where you will find resources related to today's program. If you would like a copy of the presentation, click on Slide Presentation to open and print a copy of the slides. Now, it is my pleasure to introduce today's first speaker, Kristen Engelhardt, Director of Policy and Advocacy at NCCS. Kristen, welcome to the program. Let's begin.
Thank you, Eric, and good afternoon to everyone. We are very glad that you could join our webinar, a conversation around shared decision-making and a patient revolution and the role of the Pact Act. We are very excited about the 2 related topics which are so relevant to the mission and to the core of the National Coalition for Cancer Survivorship, and we are very happy to have such wonderful speakers today. We are grateful to Dr. Victor Montori and to his colleague Maggie Breslin, as well as to Adrian Castellati for taking the time to speak on this webinar today. I also want to acknowledge our sponsors who make the Cancer Policy and Advocacy team possible. Anyone who is interested in joining the Cancer Policy and Advocacy team can find out more about it on our website by going to canceradvocacy.org/cancer-advocacy/CPAT or by looking at the drop-down menu under Advocacy. Registration for our upcoming symposium in DC next month is still open, so if you're interested in participating, I encourage you to be in touch with us. As Eric mentioned, during the 2 Q&A sessions, you'll be able to ask questions through the chat box feature on your screen, or you can ask it directly through Eric. You can also adjust the volume using the icon on your screen as shown. And if you have any questions during the webinar, as Eric mentioned, you can use the email feature or the chat box. Now, on to our webinar. We first came across Dr. Montori when reading the article, Shared Decision-Making, the Need for Patient-Clinician Conversation, Not Just Information, in the April issue of Health Affairs. As a nonprofit organization founded by cancer survivors, NCCS has long worked to promote shared decision-making, and we wholeheartedly agree with the article's support of the, quote, the need for the patient and clinician to jointly create a course of action that is best for the individual patient and his or her family, end quote. For that reason, NCCS has also actively supported H.R. 2846, the Planning Actively for Cancer Treatment, or Pact Act, which would encourage the development of a personalized cancer care plan by providing a code for oncologists to use when developing such care plans. An endocrinologist, Dr. Montori is a professor of medicine at the Mayo Clinic in Rochester, Minnesota. He holds a number of interesting positions, including investigator, Knowledge and Evaluation Research Unit, co-investigator at the Mayo Clinic for Clinical and Translational Science, and Director of Late-Stage Translational Research. His colleague Maggie Breslin, co-director of the nonprofit Patient Revolution, will also speak about their work on patientrevolution.org, a website that helps patients talk to their healthcare providers more effectively in order to get the care that they want, which is one part of the larger patient revolution. The similarities between cancer and other diseases like diabetes are incredible. Thanks to scientific advances, cancer is a chronic disease for many, but the late and long-term effects of treatments, the reason for NCCS's founding, can be extremely burdensome. And many people have difficulty commuting these problems and others, such as pain and financial toxicity, to their care team, which is why there is a need for additional tools around patient communication. And on that note, I'm turning the floor over to Dr. Montori and Maggie.
Thank you very much. It's a pleasure to be here. And this first slide has two pieces of key information that we'd like to share with you. The first one is on the bottom left is my email address. I would like folks in the webinar to feel free to write me if there are questions or issues that we don't get through during the webinar but you would like to follow up with. I promise to respond. On the bottom right is my Twitter handle, so if folks feel compelled to share with the more general world not present today here what we discussed today, feel free to do so, but use my Twitter handle so that I can follow along and participate if necessary. I'm very grateful here to be with Maggie to discuss issues of how to manage the problems of patients living with chronic disease and what opportunities we have to make healthcare work for us in the context of the patient revolution. To start our conversation, let me introduce you to Maria Luisa. And Maria Luisa is a patient from Peru, like I am. She lives in Alaska. And I would like you to spend a few seconds here looking closely at her face and her situation. And look at the walls, look at the table, look at what's on the table, look at her hands, her left wrist, look at her face, look at her eyes. With live audiences, I usually ask, what do you see? And most people quickly hone on the fact that Maria Luisa looks overwhelmed and tired. And this is in part because Maria Luisa lives with multiple chronic conditions. She happens to be on dialysis 3 times a week. She lives in Alaska, as I said, with her son and his family. She does not speak English, so she speaks Spanish with her son and her family, and mostly with family in Lima by phone. And she mostly eats a very bland diet. For patients like Maria Luisa, the challenge that we face as clinicians, so that when they come to the clinic, is answering the question of what is best for me, what is best for my family. And in healthcare, we would like the answer to those two questions to be the care that we give Maria Luisa. But it's actually very hard for clinicians, for doctors, nurses, to figure out whether the care is the right care for Maria Luisa for a number of reasons. So today we're going to be discussing some of those reasons, and before we go into that, I'd like to make sure you understand that in our work for the last 12 years since we started, we have not engaged in any financial relations with any for-profit corporations. Given the kinds of work that we've been doing, this has helped us avoid having an alternative explanation for the recommendations, ideas, and approaches that we've developed, other than what we think has been the patient's best interest. To start our discussion, I would like to draw attention to the larger context in which we live today, where people develop diseases and conditions in part because of what's in their genetic material, but in a significant proportion because of the choices that are made given the options available and because of the environmental factors. In particular, I'm concerned about violence, environmental pollution, poverty, and alienation that are contributing to people living in chronic stress, in addition to living lonely lives and developing obesity. It's interesting how much attention obesity has received as a risk factor for both cancer and cardiovascular disease, given that loneliness appears to have a stronger association as a risk factor with these concerns. The combination of these factors together is fueling an epidemic of people living with more than one chronic condition. Chronic conditions that may include cancer survivorship. This graph shows what I would think looks like a wave. On the bottom is the age groups, and on the y-axis is the proportion of people. And as you can see, it is common to see people living with one or more chronic conditions as they get older. But that used to be the case for the longest time until more recently we're beginning to see that younger and younger people living also with multiple chronic conditions, in part because they are surviving diseases that used to kill them, and in part because of the conditions I just described. The situation is such that if you look at the middle-aged group, the average person no longer is a healthy person, but a person that lives with more than one chronic condition. This means that healthcare and receiving healthcare services is increasingly becoming a part of everyone's daily lives. One of the consequences of living with multiple chronic conditions is that it doesn't make sense to refer to individual diseases anymore. So if somebody says, I have a patient, or I'm a patient with diabetes, it's kind of arbitrary that somebody says they have diabetes because they also will have depression or high blood pressure or pain. Or if somebody says they have heart failure, well, why are they now telling us also they have chronic kidney disease or high blood pressure or pain? So when we look at the way clinics are organized, or even doctor specialties, when they're organized by organ or by disease, it becomes now fairly arbitrary, really, how these patients are going to be managed, because they live with all of these conditions, such that deciding who has a particular condition invariably means that we're oversimplifying the problem. This has implications for people and the treatments they receive. On the horizontal axis, we have the problem of risk. If somebody only has diabetes, for instance, the risk of a heart attack may be less than if they have diabetes and high blood pressure and cholesterol problems. Or, for instance, in the case of cancer survivors, if they receive certain forms of chemotherapy or radiation to the chest. All of these conditions will increase the risk of, for instance, heart problems at a later time, and therefore make a better case for interventions to reduce that risk. The combination of chronic conditions can also affect their responsiveness to treatment. In the y-axis, you can see that if somebody has depression and diabetes, if you only treat diabetes without treating the depression, you won't get the full response to therapy. It is best to treat both conditions at the same time for both treatments to be effective. And then there's this problem of vulnerability, where the conditions and the treatments collaborate to cause a side effect. So in the case I'm illustrating on the slide, a patient with diabetes may have nerve problems that make them unaware of the position of their feet. Those nerve problems can also cause pain, for which an anticonvulsant may be prescribed to mitigate that pain. But the main side effect of the anticonvulsant at higher doses is dizziness. And if the patient is also aggressively treated for high blood pressure, and when they stand up, they get dizzy, you can see how the treatment of these conditions, plus the conditions themselves, have now made the patient a higher risk for falls. Some people may say, well, doctors have guidelines, and if they just were to follow the guidelines, things would be great. The problem is that the guidelines are also created one disease at a time. And if you follow all the guidelines applicable to a patient with many chronic conditions, the guidelines begin to get into conflicts and could potentially cause net harm. In this particular study, the authors found that there were many interactions between drugs that were recommended for one condition or the other by the different guidelines, and 20% of those interactions were potentially serious and could cause serious harm. Going back to Maria Luisa, we can say, well, if people were to follow the results of clinical trials, they will not get into so much trouble. If you look at the table in front of Maria Luisa, you can find that there is one drug that Maria Luisa is taking for which there is a good randomized trial evidence that these people that take this medicine will be better off. But there's also randomized trials supporting this medicine and this medicine and this medicine and this medicine and this medicine, and there's some observational studies about what she should eat and what she should drink. Knowing the evidence does not seem to prevent people like Maria Luisa from getting potentially treatments that overwhelm them, if not harm her. And perhaps, given the look of her face, she's not better off because of those treatments. So we have guidelines, we have care pathways, we have quality measures, and we have specialist care that tends to be disease-focused and context-blind. This leads to increasingly complex regimens, and if there is no prioritization or care coordination in the practice, it will lead to overwhelmed patients and families. The notion that patients can become overwhelmed by healthcare requires us to consider the notion of the work involved in being a patient. There is no medical textbook, no quality metric, no policy effort at the moment that is focused on understanding, moderating, or even measuring and becoming aware of the work of being a patient that patients and caregivers do day in and day out. There is no research about the structure or the content of that work, and as a result, there is no effort to support this work in a systematic way. In fact, only recently, our collaborators in the UK came up with this framework for understanding the work of being a patient, a framework that I find very helpful. It starts by recognizing that patients have to do the work of making sense of the work they have to do. This is why patients join support groups and other patient groups online. This is why they read the package inserts of the medicines that have been prescribed. This is why they Google their symptoms and treatments to try to understand things better. If they don't do the work of making sense of the work, they will not do all the work that is necessary. They will not know where to cut corners when those are needed, or ask for help where that's necessary. Then there is the work of organizing the work and enrolling others. In this picture, the gentleman in light blue shirt is the patient. He was minding his own business, watching the game on a Sunday afternoon when his wife called him again, as every Sunday, interrupting the game, to come to the living room to set up the pillbox. It is her organizational skills that keeps him compliant or adherent to the medication program. It's setting this pillbox that helps him take the pills in an organized way and helps her know that he's taking his pills. It's a partnership. She has been enrolled by him to do this work. He doesn't look very sick. If anything, maybe looks a little lazy. So the only reason she's enrolled in this work must be because of love. So he needs to do the work of keeping her in love, which is, of course, I'm sure, a full-time job. But notice that she has a medical alert bracelet on her left arm. She is herself a patient. If she were to fall ill or go to the hospital, he will have to do this work by himself, and he does not have either the discipline or the organizational skills to do it. He'll just take the pills from the little orange containers, and we know that's not going to be a good thing for his care. Then there is the doing the work itself. It is going to the appointments, getting the prescriptions filled and refilled, paying the bills, arranging and coordinating appointments, etc. So this is the core of the work that needs to be done. And then finally, it is a reflection, monitoring, and appraisal of that work. In other words, is the work that we're doing worth doing? And if so, I will continue to do it again tomorrow. If any of these steps is not done, then the work of being a patient will not get done. And if that work was associated with effective care, patients will suffer poor health consequences. Because we are not aware of all this work, in healthcare, we've decided to create new work and to transfer that new work to patients and caregivers. We're now demanding that people prepare for the consultation, that they watch our nifty educational video we just put on YouTube, that they bring questions and be ready for new ones, that they record the visit and review the visit at home so that they will not miss any details, that they review the medical record that we now give them access to, and by the way, help us find any typos or mistakes, particularly if now your mother has a normal prostate exam, we need to correct that, given that she's not supposed to have a prostate. You need to communicate with us via the portal and transmit data about your measurements, self-monitoring, and self-management. You need to manage your appointments, your prescriptions, and your bills, and your "this is not a bill" that you get. You need to keep your family and important others informed. You need to take care of significant others. And by the way, you need to help us advocate for better care. Well, each individual task has enormous value and great potential, but when patients are asked to do more and more and more of that work, invariably they'll become overwhelmed, particularly because they rather use their energy for other activities. We know this is beginning to be the case. This is a survey that was published last year that shows that Americans over the age of 65 are reporting that healthcare is asking for too much work, for work that is too hard, and as a result will get delayed or not get done unless it can be delegated. And the people that are being less able to get all this work done are people with less capacity to do the work, people with lower socioeconomic status, or people who are sick. When people don't get the work done, we'll label them as non-compliant. This is a big problem because when you label a patient, as a clinician, you label a patient as non-compliant, this is a commentary on the patient's character. And it's a label that cannot be shaken, and it paints a picture in the doctor's or the nurse's mind that this is an undesirable patient. Reflect on this. Would you invite a non-compliant patient to your birthday party? I would be afraid that the patient may show up without a gift. And so as a result, this is a dead end for the patient, and it's a dead end for the clinician's ability to help the patient. Non-compliance is not only a bad word, but operationally it actually makes us stop caring for people. So we need to change it for something better. To understand why the work doesn't get done, we need to understand that there's a given capacity to get the work done. And different components or different aspects of a person's life contribute to the capacity to get the work done. Is there a purpose in your life that fuels or pushes forward? Are you resilient and able to bounce back from adversity? Do you have enough literacy to understand the work that you do and know when exceptions can be made? What is your ability to think through the situation that you have, or are you worried sick and unable to make good decisions? That's what is referred to as bandwidth. What is the situation of your physical health? Do you need a cane? Do you need a walker so you can move fast and you can get things done? Or you need more rehabilitation so that you're not so short of breath? What about your mental health? Are you depressed and everything is like molasses and moves very slowly so only a few things get done? What is your financial capacity, your financial health? What about social resources? Do you have the skills to ask for help? And on the other hand, do you have enough of a social network of people that you can approach and ask for assistance? Or are you lonely and isolated? And also environmental resources. Do you have access to the internet? Do you live close by to resources, or are you far away from town, from the city? So these things contribute to the capacity to do the work of being a patient. So instead of talking about non-compliance, we probably want to start talking about an imbalance of workload and capacity. And this can result from too much work or too little capacity. We've reviewed a source of capacity, but let me point out that when we talk about too much work, sometimes it is that we doctors are asking too much of patients. But it also may be that life is asking for patients' attention and commitment. People get fired from jobs, get promoted from jobs. People get new family obligations that they have to do, or community challenges they have to face. And life is a lot more motivation. It carries a lot more meaning than the work of being a patient. So when life comes knocking, you attend to that, and if you have limited capacity, you will not get the work of being a patient done. As a diabetes doctor, I've seen this a million times. Patients are doing quite well. All of a sudden, their diabetes is out of whack, and my colleagues and I may be interested in intensifying the treatment to get the diabetes under control. But under this framework, we have to understand what's going on, and in understanding what's going on, we often find out that fundamental changes in the person's life have now required that they pay attention to those aspects, and as a result, they have less attention, energy, and time to be patients. I take care of a lot of farmers, and for instance, during the period of harvest, in which their income is determined for the rest of the year, the care of their chronic diseases will inevitably suffer because most of their attention is on the farm. In the process of determining what work they pick up, it is sometimes helpful to engage patients in shared decision-making. So I'm going to show you a couple of examples of ways in which we do it. One relates to interventions to prevent adverse effects. So here is an intervention for a 55-year-old man who is completely healthy, has no risk factors for heart attacks or strokes. Such a man will be shown this graph. On the panel on the left will be the situation without any treatment, and we will tell Mr. Jones that he's in a room with 100 people just like him. We're going to close the door of the room for 10 years. After 10 years, we'll open the door and we count, and we'll find that 92 people just like him would not have had a heart attack, and 8 people like him would have had a heart attack. And we'll tell Mr. Jones that we do not know if he's one of the green ones or one of the orange ones. Now, if Mr. Jones is curious to know what could be done to reduce this risk of a heart attack, and is interested in pharmacologic and drug approaches to prevention, we'll talk to him about statins. And if he's interested in knowing the effect of statins, we'll look to the panel to the right, and we'll give a statin to those 100 people just like him, ask them to take it every day, close the door. 10 years later, we open the door and we count, and 92 people that were not destined to get a heart attack would have taken medicine every day with no benefit. 8 people that were destined to have a heart attack, 6 will still get their heart attack despite taking the medicine regularly. They will not get any benefit. And then there will be 2 people in light blue that will be saved from having a heart attack by taking the medicine regularly. We will tell Mr. Jones that we do not know if he's one of the green ones, one of the orange ones, or one of the blue ones. And then he can then suggest at this point whether this is an intervention he would like to proceed with or not. At this point, I can say that less than 10% of patients presented this information with this level of risk will go on to say, I'm interested in taking this medicine. Of note, current guidelines indicate that anybody whose risk is over 7.5% should take this medicine. This patient we just discussed has a risk of 8%, so it qualifies according to the guidelines to take this medicine. I suspect the people in the webinar are looking at this, and at least 90% of you are thinking that you may want to deviate from the guidelines and not take the medicine. Another approach to doing this is when more than one treatment is available, is using these issue cards. This is I'm going to demonstrate how we do it for people with diabetes who are not getting good sugar control with one medicine and are interested in, let's say it's metformin, and they're interested in their second medicine after trying with diet and exercise and not lowering blood sugar sufficiently. So we will ask them, what aspect of your next diabetes medicine would you like to discuss first? They will look at the titles of those cards on the left, and many of our patients are concerned about their weight, so they may choose the weight change card. As they look at this card, they quickly recognize there are 2 interventions, one in the middle, one on the bottom, that help lose weight, and they'll be very interested in learning about something more about those 2. In that situation, we'll ask them, okay, what aspect of those 2 medicines would you like to learn about next? And many of our patients will choose the daily routine card, which tells them whether these are pills or injections. In the middle, it's an injectable medicine. When this was the only medicine that could help you lose weight, many of our patients demonstrated quite a bit of interest in using the injectable medication. As a diabetes doctor, the only injectable medication I could offer before was insulin, and I had to really work hard to get people to consider insulin in their lives. But when this medicine appeared and people were able to lose weight on this medicine, patients all of a sudden were quite interested in injecting the medicine, even if they had to inject their eyeballs, which of course they didn't have to, but they were willing to do that. When the second medicine, the one on the bottom, became available as a single tablet, that became quite interesting. And a patient may be interested in that particular medicine. The one on the bottom, single pill a day that helps you lose weight. So then we ask them, okay, what aspect of that medicine would you be interested in learning about next? And the patient may be interested in knowing what the out-of-pocket cost will be for that medicine. They're used to metformin, which is 10 cents a day, and they realize these SGLT2 inhibitors are $8 a day, so 80 times more expensive. And patients could ask, oh, is this 80 times better? I said, well, no, the drug company just got 80 times greedier. Oh, okay. So if somebody is not cost-sensitive, maybe they want to try this particular medicine. If somebody's cost-sensitive, their eyes will immediately go back to the weight change card and look at that one that they were willing to inject their eyeballs with, and they realize that's an $11 a day medicine. They realize perhaps they can't afford medicines that help you lose weight. They look at the weight neutral gliptins next to the last. That's a 1 pill a day. That's very nice, but that's $7 a day. Maybe they can't afford weight neutral either. There's a mild weight gain one, sulfonylureas. That's a single pill a day, and that is 10 cents a day, like metformin, and that may be the medicine that's best for them. This replaces the existing approach to selecting diabetes medicine, which is based on a complex algorithm that only doctors could use to tell patients what to take. And we've demonstrated in clinical trials that having patients participate in what is essentially a process of identifying treatments that have differences that matter to patients is actually completely feasible and satisfactory. And we've done it not only in diabetes, but we've also done it in the selection of antidepressants in primary care, a clinical trial that we just published at the end of last year. In our experience over the last decade with shared decision-making, a number of myths have fallen off. We were told initially when we started that this will only be for young people. And the age group here will show you that a whole range of people benefit from this sort of activity and are able to participate quite effectively if you just design the experience properly. We were also told that this will only be for specialty care where long visits are available, but we've been able to make it work in primary care, in the emergency department, and in the hospital as well. We were told that doctors will never want to use this intervention, and that has not been their experience at all. We were also told that it would take too long, and on average, these interventions take add about 3 minutes to a consultation. We were told that it would require a lot of training, and that seems not to be the case. We were also told that it would just make disparities in care worse, where people that already are highly educated and are privileged and have access to doctors with a lot of training and time will get the patient-centered care, and the rest will still get, the not-so-good care. And what we found is that when patients have access to these tools, even if they belong to vulnerable groups, made vulnerable by the color of their skin, the level of education, or their bank account, we are able to see that those patients actually benefit to a greater extent than the privileged patients that probably have access to the same information before the visit. As a result, if anything, this intervention appears to be a bit of an equalizer. And we were also told, and this is in the Affordable Care Act and in a number of state laws now, that shared decision-making improves outcomes, reduces healthcare utilization, reduces cost, and improves adherence. That is not true. The effect on those outcomes is quite variable, and it's actually very hard to find studies that in fact show that shared decision-making reduces costs or make outcomes any better. So the fundamental justification for shared decision-making remains that it's the right thing to do to make sure that the care reflects the context, values, and preference and evidence relevant to particular patients. Finally, we were told that nobody will use this tool, and our current statistics show widespread use of the tools we've been able to produce. They're freely available, and you can see the distribution of countries around the world that are using the tools, and also the distribution of states of the Union that are using the tool. And I think if you look carefully, you'll notice that every state of the Union uses our tools, and they're currently clocking at about 12,000 uses per month. So this is something that we can do to reduce the burden of treatment, or at least to right-size the burden of treatment to the situation of the patient, as well as the patient's values and preferences for shared decision-making. Pharmacists can also engage in de-prescribing so that legacy drugs that may have had a reason to be used at some point, get discontinued so that we can reduce the number of drugs and therefore the number of tests and visits that are necessary for patients. Coaching to improve patients' capacity and use of resources may be helpful, as well as self-management training, which is increasingly available in many communities. Palliative care plays a huge role here. If you can't sleep or you live in pain, that reduces your capacity to not only do the work of being a patient, but also to live your life. And it's an important component of holistic care that should not be used only at the end of life. Mental health, obviously, is very important, as it is physical and occupational therapy. That may improve your physical health capacity and your ability to get things done. If you can't run, if you cannot walk fast, then it will take you longer to get some of the things that you have to do through the day. Here's Maria Luisa. When her family left for the day to work, If she was on the top floor, that's where she would stay for the day. If she was on the ground floor, that's where she would stay for the day. By installing this little elevator, which required mobilizing some financial resources and community resources, she was able to actually gain quite a bit of independence within the house that allowed her to get more things done in the day, increasing her capacity. We have developed tools like this one that allow clinicians to discuss with patients the sources of capacity they have and the things that are sapping some capacity from their daily activities. With clinicians discussing issues here in yellow and potentially issues here in green, with patients completing this before the visit. And then the discussion then becomes what jumps at you, what appears to be a source of help, what appears to be a source of burden, or both, and how we can use the sources of satisfaction or help to boost your capacity, and how can we mitigate the sources of burden so you can have more energy, attention, and time to live your life and pursue your hopes and dreams. The stuff in white may not be something that your clinician or nurse may be comfortable with, but a social worker, care coordinator, or other health professional might be brought in at that point if there are elements in there that could be addressed. It doesn't matter how much we do in the consultation if the healthcare organization insults or at least is not careful or not kind with the work that it imposes on people. This is a great picture. I wish I could credit it because I can't find where this came from. But this is a picture taken of a service desk, and patients having gotten tired of standing in line have their shoes stand in instead of them. And this indicates an organization that does not recognize that these users are sick, and as a result imposes more work than the patients are willing to take. But it's also important that we look at the communities that we have and the communities that we're helping contribute to and building. Are these communities that lead to cohesion and support of each one of us, and such that when we get sick or when we live with chronic disease and we need support, there's someone there to help us? Or are we creating communities that isolate individuals and as a result leave them with their own resources as the only capacity they can mobilize, not only to be a good patient, but also to pursue their life, work, and expectations. So it is not just about what we see in clinical care, but it's the way healthcare organizations do their work and the way communities are being built to support patients living with chronic disease, including cancer survivors. Which brings me back to Maria Luisa and to everyone in the call that is a patient. You know, the key question of what is best for me, what is best for my family. We hope in healthcare that we can address those two questions by saying, yes, it's our care, the care that we provide to you, the care that is careful and kind, is the care that you need, is the care we're giving to you. When we do that, we get this. The person to the right of this picture, her name is Anna, and she spent a year with her research group understanding what I just described to you, which we call minimally disruptive medicine. And when she went to visit her grandmother in Alaska, she realized there was an opportunity for her to implement what she had learned with us. She got lucky because when she was looking at the schedule of dialysis, she noted that her dialysis was in the mornings, and she was wiped out for the rest of the day, which basically make her a part-time person, living as a person only 4 days a week, while the 3 days of dialysis were essentially lost. So she looked for a dialysis appointment in the afternoons to give her at least three additional mornings. The lucky part of that was that in the afternoon, the dialysis staff included 2 nurses that spoke Spanish, which increased the social network of Maria Luisa. Also, Maria Luisa had more energy and started doing crochet, which connected with her granddaughters, and that gave her a little bit of a reason, a little bit of a purpose to live, something that she was all but lost. Anna also connected with a dietitian in Peru, provided dietary guidelines that were given to Maria Luisa in Alaska, but tried to satisfy them with recipes that would remind Maria Luisa of the good Peruvian cuisine, and identify someone in Anchorage that was able to cook for her and leave once a week and leave the food ready for her to pick out from the fridge during the rest of the week. She was able to have a flavor that reminded her of good times in Peru and made her happy. Minimally disruptive medicine is able to then move Maria Luisa from this situation to a situation where she can enjoy her life with her family. That is the goal of healthcare, and that's what we all should advocate for. A work that puts the patient first, and a work that is able to provide a patient like Maria Luisa with kind and careful care. I'm going to now transition to Maggie, who describes the work that we're doing with the Patient Revolution.
Great. So my name is Maggie, and I have been working with Victor and the research team here for about the last decade. And I'm a designer and was part of the collaborative team that really developed the approach to developing a lot of our tools to kind of help encourage and support conversations between clinicians and patients. And we've been, like I said, we've been doing that work for about a decade, and a couple of years ago, we got the opportunity to begin exploring what might happen if our only avenue for getting these tools into the clinical encounter wasn't solely through the clinical side, but what might happen if we could actually catalyze patients pushing this information towards the healthcare system, and what effect might that have in terms of really prioritizing and changing the system that we've got to one that does support more careful and kind care. And so that's something that we've been working on for the last couple of years, and just quickly I'm going to walk you through some of the tools that we've developed as part of that work. So when we started thinking about what would it mean to build out a program like this, we took a couple of insights from the work that we've done over the last decade, spending a lot of time observing and talking to patients and clinicians. And one thing that we know is that patients are experts on their lives. They know about what they have the capacity to do, what is their biggest priority, and what is going to potentially bring the most meaning and kind of value to their lives. You see this come out for patients in the stories that they tell. The stories that they tell and the questions that they ask, these are the windows to the things that are important to them. As someone who's observed a lot of conversations between clinicians and patients, that it's an extraordinarily intimate and rewarding act. When two people are able to come together, hear each other, and respond in a way that leads to a solution or a way forward that is respectful of what's important to both of those people. It's certainly very meaningful to patients, but it's actually also just as meaningful to clinicians. And then the other thing that we know is that speaking up in the clinical encounter is extraordinarily hard. We essentially conditioned patients for decades that their role in that space was not to speak up and ask questions, and simply saying, patients, now you should do that is not in any way, shape, or form enough, because you sit in those places and you have the kind of history and ritual of those places, and it can be very, very hard to find the way to kind of challenge or express a sentiment to your clinician. And as we did a lot more research, we began to identify what we call kind of the 8 barriers to being able to speak up or engage sometimes with your clinician. And these can be fear of being a burden, fear of being judged, the fear of being labeled as a difficult patient, which similarly to the idea of being non-compliant is a label that can follow a patient around throughout the rest of their care, and is very frightening to patients, the idea that they will get a label that will keep the system and the clinicians that they come into contact with from caring with them. They can be afraid of saying the wrong thing. We also attach a sense of urgency to essentially all decision-making, when truthfully there's very few decisions that have to be made right that second. And that most decisions could potentially benefit from time for patients to kind of think it through, but that isn't always made clear or made evident in a doctor's visit. Patients have a sense that stories about their lives don't necessarily belong in a clinic visit. A story about a sibling that's suffering from mental illness, or a friend who is going through a divorce that's been kind of creating a lot of stress and anxiety in your own life. People don't always feel that those things have a place in that space, but of course they do, because they're critically important to this particular person. There's very little discussion in the clinical encounter about risks and benefits. and then very little about costs and money. So even though, financial decisions have a huge part of how people make their healthcare decisions, we've kind of created a taboo about how they don't really belong in that clinical encounter. And so what we did is we took a lot of those insights and we started to say, okay, so what would it mean to begin to support and skill and encourage patients to be able to speak up a little bit more and to be able to express some of the things that are most important to them in the clinical encounter. And we've begun to build some tools to do that. So one is a care conversation workshop. So we've had a number of these we try and have them oftentimes in public spaces that are not clinical spaces. So we've had some at the public library. We've had others at community and meeting kind of halls, some condition specific, some where we've just invited different patient groups. And the idea is that we have patients come together using some of our barrier cards. We have them talk about their own stories from their own experience of when they've encountered these barriers and how they kind of manifested, and then also to begin to think about a conversation that they might like to have with their clinician and begin to kind of sketch that out. Oftentimes what we do with that is on this page on the Plan Your Conversation cards and a practice session. And so we devised these 5 cards, which are condition agnostic, to begin to help patients structure a conversation that they might like to have with a clinician. What they want to talk about, why it's important to them, what they feel it might help the clinician to know, where they're hoping the conversation leads to, and where they're nervous that the conversation will lead to. And in our workshops, we have patients fill out these cards, and then we pair them together, and they practice with each other, kind of practice saying out loud, these are the things that are important to me, and these are the things that I'm worried about. And we have begun to get reports back that act of practicing and actually writing something down helps bridge that fear or that barrier that they may have about sharing this with their clinician and allows them to begin to insert something that's really important to them into the clinical space. We've also created a tool that's a reflection document that can be used in the clinical encounter. This is sort of 4 key questions that patients can fill out before the doctor kind of comes in and the physician can kind of use to guide their conversations with them. So it's tell us one non-medical thing about your life that you think the doctor should know. What is one thing your doctor is asking you to do for your health that's helping you feel better? And what is one thing your doctor is asking you to do for your health that feels like a burden or feels harder than it should? And then also, where do you find the most joy in life? We have prototyped this tool in collaboration with a primary care team up at Yale New Haven Hospital, and the insights have been really interesting. We found that oftentimes people listed the same thing under the idea of what one thing the doctor is asking you to do to feel better and the thing that feels like a burden or feels hard. And it was interesting because many patients, what they really wanted to be able to kind of say to their doctor and feel heard by their doctor was the idea that they were trying, that they were making an effort, even if they hadn't fully accomplished whatever sort of the aim was. It was very meaningful to them to have the physician acknowledge that they were making an effort and that effort had value for them. And we had one patient who where it said, where do you find the most joy in life? He was in the clinical encounter with his wife, and he said sex. And his wife was filling out the form for him, and she kind of gave him a funny look, and then she wrote in the box, love life. And it was, we were talking to the physician afterwards, and the physician was saying, like, oh, that's such wonderful and great information for me to have because, of course, there's lots of medications that can have side effects that affect sexual function. And if I know that this is something that's important to this person, I can use that information to kind of filter through all of the treatment options and all of the knowledge that I have to help find something that is going to allow them to kind of prioritize something that's clearly very important and meaningful in their life. And so that's just a quick little snapshot of some of the tools and things that we're developing. And the idea is that we're really looking for patient and community collaborators so that we can continue to develop more tools and experiment with what happens when we when we put these skills and tools in patients' hands and then encourage them to bring them to their clinical encounters and begin to report back to us kind of about what happens in that space. So like Victor said at the beginning, you can find some of these tools. I know some of you have reached out already, which is wonderful, at our website, patientrevolution.org. You can certainly reach out to me on email and also on Twitter at @patientrev. And if this is exciting to any of you, we're looking for more people to join the revolution. And with that, Eric, I'll pass it back to you.
Thank you very much. We will have our first question and answer segment of the webcast now. If you'd like to ask a question, simply type your question into the chat box area located on the lower left corner of your screen. Once you have entered your question, click on the send button located next to the box. Your questions will not be viewable by other attendees. You can also ask a question through the phone if you are dialed in. To ask a question, simply select *1 on your telephone keypad now. Please note that *1 will not work if you are using a speakerphone. Please pick up the handset before selecting *1. If you are waiting to ask a question and decide you no longer wish to ask that question, select *2 to remove yourself from the phone queue. Kristen, we're ready for our first question.
Great. Thank you, Maggie and Dr. Montori. That was actually fascinating. We have one question through the chat box, and that is first a comment that it's a great tool for chronic disease for which many treatment options exist. But the question if there's any applicability of the tool for non-chronic diagnoses.
Yes. The best example was published, I would say, about 2 or so weeks ago by our colleagues in the emergency department. Patients approaching the emergency department with chest pain, acute chest pain. The majority of those patients actually are at very low risk of having a heart attack at the time, but they're obviously very scared. In our emergency rooms in this country, about 80% of those patients are admitted for observation and stress testing. Some of them have positive results and go on to get angiograms and stents and other interventions. But I told you the vast majority of them are at very low risk of a heart attack. So all that activity was weird and difficult to understand beyond the issues of risk of lawsuits for the emergency doctors. So my colleague Eric Hess and his team developed a tool like the ones we've shown you today to help patients understand what their own risk was of developing a heart attack in the next 40 days and the options of staying in for the kind of care that I just described, or to go back home and see guaranteed an appointment with their primary care doctor or a cardiologist within 72 hours to determine whether they needed additional testing or additional treatment. The results of the trial, it was done initially here at Mayo Clinic, and then it was done in a multi-center trial. The results of the multi-center trial are in, and they confirmed the result of the trial here at Mayo Clinic in that the majority of patients that were offered the choice decided to go home and to pursue the visit with their primary care doctor or cardiologist, and no additional testing was ordered by the primary care doctor or the cardiologist. And so, again, it was interesting that the care appeared to now reflect better the fears, values, and preferences of the patient rather than the interest of the doctor or the hospital.
All right, great. Thank you. Another question, if you have any suggestions for bringing these ideas with the VA? Is there a way to implement these ideas in the VA system?
Yeah, so more than suggestions, I can tell stories. And so perhaps the most remarkable of the stories is in the Milwaukee VA at the Women's Health Clinic. They are the national pioneers in the implementation of minimally disruptive medicine and using the tool ICANN, which is the tool I showed with the 3 areas in white, green, and yellow, that allows the patients to report the sources of their capacity. They're using and testing that tool in the VA and in Milwaukee. If anybody's interested in learning more about that particular experience, they can go to minimallydisruptivemedicine.org, and their story is in the blog area. So minimallydisruptivemedicine.org, and you click on the blog and then type in the search box VA, and you can read that particular story.
Excellent. Thanks. Right, so the next couple of questions, Maggie, may be directed more towards you and the Patient Revolution tools on the website. One question is whether these tools will be implemented through the clinics or if they're available for patients to get the tools to take to their clinics if the clinic, or to use at their clinics if the clinic doesn't provide them. And a related question is whether nonprofit community organizations that support clients can help their clients complete the tools to take to their appointments.
Absolutely. So really our idea behind the Patient Revolution tools is to put them in the hands of patients and then have patients kind of bring them to their clinical encounters. And we are absolutely looking for community collaborators and partners to kind of help get these to people that feel like they would benefit from them. So we're in the process of kind of pulling these pieces together and packaging them so that we can make them available to community groups and also to individuals in lots of different forms. The one key thing that we're really asking people for is that, you know, we are a research group and we do very much want to continue to learn. And so we're kind of asking anyone who engages in use of our tools to kind of join with us and report back about what happened so that we can begin to understand what they're doing well and what other spaces might exist for us to create other tools or what else we could be doing to kind of help support patients in doing something which can be a little bit scary and does sort of maybe push them out of their comfort zone a little bit. So if you reach out to me either through email or through the website, as those will be coming together in the next couple of weeks, and would absolutely love to get them in people's hands. And
standpoint of implementation through the clinics, we have a track record over the last decade of doing so. The thing that perhaps folks need to know is that all the tools are freely available. So any clinic that would like to implement them into their workflow can just take the tools off the web. They don't have to tell us, but as Maggie pointed out, we're interested in hearing about the experience. We are working hard to try to find ways in which these tools can be implemented in the electronic medical records that are commonly used in practices so that they can be integrated into the electronic workflows as well. And so they're free, they're available, and we're hoping to provide support to clinics. So we hope that these tools can get through the practice either by patient organizations, and this is where the Patient Revolution plays in, or in partnership with the healthcare organizations, and this has been our track record up to this point. So I think that addresses that particular question. Again, if people want to see the tools, they can be found at shareddecisions.mayoclinic.org.
Great. Now we have a question about how providers have responded to receiving the reflection document for their patients. Do you have any suggestions on how to help providers understand the value of using this information to improve patient-provider communication, patient outcomes, and patient satisfaction?
Yeah, so we're kind of in early days with the reflection document in terms of kind of getting it out into clinical practice. That's one of the newer tools that we've developed. But we have, you know, essentially where we are initially targeting is clinicians who, upon seeing Victor's talk or my talk around Patient Revolution, who are drawn to and excited about these ideas. Because we found that having somebody who is invested in it and also is a known entity within their clinical group is really important to kind of introducing these ideas and helping people, helping their other providers kind of get excited about them or understand how they might position it. We also, these tools are all developed using a process that's called kind of human-centered design. And so oftentimes what we will do is we'll ask or encourage people to say, try the document for a day or a week, you know, so because quickly sometimes the question or the challenge can become how do you fit it into the overall processes and systems, and that's a very important piece that ultimately does have to be figured out. But before you kind of move to figuring that piece out, you might just try it on a very small scale because, like the story I told, you find that patients begin to reveal information that allows clinicians to actually care for the person who's in front of them and to make a meaningful connection with them, and that is very rewarding. And that having that rewarding act happen makes them much more invested and interested then in figuring out how to fit it potentially into some of their larger processes and systems. So I think we have, over the last decade of working in clinical places, we have some ideas and insight about how you begin to move these types of ideas through an organization, but it's kind of a human engagement process. That's what we found really works well, and to continue to stay focused on will feel good.
That's a great point. A related question: when people get a diagnosis of a serious life-threatening disease like cancer, it's very hard to question an oncologist's treatment plan when the side effects of a cancer treatment can be significant. Do you have any suggestions for how cancer survivors or caregivers can raise this topic with a physician without his or her replying along the lines of, let's save your life first and then worry about side effects?
Absolutely. So, I think one of the things that we've really tried to embody in the patient revolution work in particular is, the idea of asking patients to prioritize or ask questions and to sort of move them into the space of of talking in medical terms or sort of using that type of language is very difficult, because they obviously, we send doctors to school for a really long time to do what they do. Patients are probably never going to be able to kind of play on that field. But again, what patients are experts are is their lives. And I think what we really encourage people to do is not so much take a stand of questioning or kind of pushing back against the clinician, but instead to take that opportunity to tell that clinician something, or that oncologist, something that's important to you. And something that may be about something that you're looking forward to doing, or something that's critically important in your life that you would really like to keep doing. And being able to express that, if you bring that into that space, then what we've seen very often is that the physician will pick up that information and begin to use it to cycle through the options or the information that they may have. So that the requirement isn't necessarily that the patients find a way to be challenging. It's instead that they find a way to share something that's important to them. And that we've seen that, certainly not in all cases, but in many, many, many cases, the physicians will pick up that information and kind of go with it.
I have maybe a more violent answer than Maggie, in the sense that I have found in cancer that many clinicians have attributed major improvements in survival to the ongoing testing of new and better pathways to care. They are correct. They are right. But in many cancers, the treatment pathways have been established for a long while, and they are used more to reduce the opportunity to tailor the treatments to the individual situations of patients. In that case, I think it is important for the clinicians to recognize when it is time in the life of a pathway, in the life of a treatment for cancer, when is it time to begin to account for unique patient circumstances and unique patient values and preferences. This lack of interest, or momentum that the treatment pathways have, that shuts patients' individual circumstances out of the equation, leads to the overtreatment of cancer patients that is so common, particularly at the end of life, where you almost have to pull the oncologist out of the room so they stop their chemotherapeutic treatment on patients who clearly have turned the corner and they're no longer going to survive their cancer. And some of the crises that we have of bringing hospice care too late or palliative care too late to the bedside have to do with this excessive adherence to treatment pathways that, again, on the one hand, can have produced significant improvement in survival, but on the other hand, are used inadvertently, I think, as a tactic to leave the individualization of care to individual patient circumstances out. I don't know that patients can do this one person at a time, particularly when they're sick. So this is the role, I think, of advocacy organizations, interacting with professional organizations, looking for opportunities in pathways and protocols and guidelines to introduce a notion of shared decision-making at key points in those pathways. Again, I don't think it's something that you do at the bedside one patient at a time, but something that we take a step back and try to do by influencing the culture of the specialty.
That's a great point to think about shared decision-making and to be included in the pathways. And I'd love to ask you one more question from one of our webinar participants, but I am mindful of your time. Do you have time for one more, which I think may be quick?
Yeah, so if you make the question quick, I'm guaranteed to make the answer long, so go for it.
All right. Have you found, as more patients are surveyed, are any patients actually reporting that they are burned out from the surveys?
Absolutely. Patients with multiple chronic conditions get seen in multiple parts of the healthcare system by multiple healthcare professionals. Each of them may be conducting their own quality improvement activities at the local level. That implies some degree of survey consultation, the tools that we've shown and other tools that maybe are required for reimbursement, PHQ-9s for depression screeners and things like that, quality of life measures. These are all applied to these patients, and to the extent that they have multiple chronic conditions, they accumulate also surveys that they need to respond. We work here in the Mayo Clinic in Rochester, Minnesota. Rochester, Minnesota is the home of the Rochester Epidemiology Project, a project that has ongoing surveys of patients over their lifetime, in addition to having complete records of all those patients. There is also now a biobank that collects information about them as well as tissues. So people that have multiple chronic conditions and live in Rochester, Minnesota get even more surveys than that. And as a result, when we started exploring this notion of the work of being a patient, we were surprised, and we shouldn't have been, but we were surprised that patients were particularly overwhelmed by the number of surveys they had to complete. And one particular patient sticks in my mind. He was a military guy. As a result, he knew that he needed to complete all surveys at all times. And he and his wife were both patients, and they both live here in Rochester, and they both have multiple chronic conditions. And when we were able to account for all the surveys they were completing, it was mind-boggling. So we came back to the institution and asked to see who was monitoring the surveys that the institution was producing and sending to patients. And it was fascinating how at the Mayo Clinic there was only one kind of survey that was carefully monitored for responder burden, and that was the research surveys. But all the practice surveys were actually conducted individually by each practice without any coordination of effort. This actually works out well if you only have one condition and you only see one area, but it's a nightmare if you're seeing in multiple places. So the general point about this, however, that I want the audience to take with them is that if you design healthcare to meet the needs of your patients with multiple chronic conditions, including cancer survivors, in all likelihood you're also meeting the needs of your patients with a single condition. But if you design your system to meet the needs of people with single conditions without accounting for the burden of treatment that you can impose to somebody that has more than one condition, you're going to struggle. And so to that extent, the patients with multiple chronic conditions are like the proverbial canary in the coal mine. You see, the canaries were brought down to the coal mines to pick up if there was any toxicity in the air, so that if there was any toxicity, the miners could be pulled out of the mine in time without any deaths. The way the canary worked is they would bring the canary down, and if there was too much toxicity in the air, the canary will, and if you thought the canary will die, you're wrong. The canary will get restless, and then the canary will stop singing. So another way of imagining what we've been discussing over the last hour is when patients no longer can do the work of being a patient, when they stop showing up for appointments where they can no longer take the treatment, they're like the canary that has stopped singing because the healthcare that we're able to produce for them has become toxic. And if we are able to pick up those signals, not as a way of blaming the patient, but as a way of as stimulate to redesign the system, we might actually end up with care that is both careful and kind. And that is our purpose, and I think we'll find a lot of people in the call that will want to join us in pursuing that goal.
I think you are right, and we're seeing lots of comments and compliments to you in the chat box. But I am mindful of the time, so I want to thank you both very, very, very much for participating in the webinar today, and we would love to continue to work with you.
Great. Thank you so much. Yeah, we look forward to future collaborations.
All right. Excellent. Thank you. Now, I'm actually going to backtrack a little bit to Dr. Montori's comments about shared decision-making being in the pathways, which is a great segue into our discussion about the Pact Act. And Dr. Montori had also mentioned in one of his slides that poor care coordination is often a problem in our healthcare system. And care coordination is actually addressed in the Pact Act, or the Planning Actively for Cancer Treatment Act. And I'm very happy to be able to introduce to you now Adrienne Castellati, the Deputy Chief of Staff for Congresswoman Lois Capps of California. A nurse herself, Mrs. Capps has worked throughout her career in Congress to improve the healthcare system. And we are grateful to her and to Congressman Bustani of Louisiana for introducing the bipartisan Pact Act together last year. But before I turn this over to Adrienne, I want to mention that we have a page on our website on canceradvocacy.org that is dedicated to the Pact Act, where you can quickly take 2 minutes to email your member of Congress to ask him or her to co-sponsor the legislation that can make a difference in the lives of so many cancer survivors. You can get to that page from almost any page on our website by clicking on the blue and white icon that says Pact Act, or by going to canceradvocacy.org/cancer-policy/pact-act. And now, Adrienne, it's all yours.
Okay, thank you so much, Kristen. Hi, my name is Adrienne Castellati. As she said, I work for Congresswoman Lois Capps, and I'm just going to speak briefly about this legislation that we've been partnering with the National Coalition for Cancer Survivorship on over many years, and that we're really hoping we can move towards the finish line this year. So as she said, the Pact Act is the Planning Actively for Cancer Treatment Act, H.R. 2846. And just get on into it. I'm hitting the button. It's not going forward. Oh, there we go. So more than 1.7 million Americans will be diagnosed with cancer in 2016, and almost 14 million Americans have a history of cancer. This we know. And many of those newly diagnosed and those living with cancer will receive the best that the American healthcare system has to offer. However, even those who receive outstanding care report gaps in the cancer care system. And this was just talked about in the beginning part of the webinar. But most patients do not receive written plans explaining the diagnosis, prognosis, treatments, and expected symptoms of their care, leaving patients to navigate the complexities of a cancer diagnosis without much guidance. We also know that this isn't just a personal experience. This has been documented. So in the 2013 IOM report, Delivering High-Quality Cancer Care, Charting a New Course for a System in Crisis, they did say that we have a system in crisis, but their number one recommendation was to support cancer care communication and planning. That's the research side, but then we also know that we talk to providers, and some of them are doing this, some of them want to be doing this, but it takes time, and the way that our system is set up, they can't necessarily take the time that's necessary to have these important conversations. And similarly, patients want a roadmap. Cancer care planning encourages the shared decision-making about how to move forward based on both medical evidence and patients' wishes. And when folks are invested in their care, they have a better sense of what's going on. They can be more engaged going forward, just which the previous presenters spoke about the amazing program that they've put together to get people more involved in their care. And that's what we want to make sure is happening, not just for the select few who have the providers who are willing to take the time, who are able to take the time, but that it's across the board benefit. So to do that, and wait a second. Yeah, there we go. The Congresswoman has authored the Pact Act, and this is based off of cancer care planning legislation that she's authored and introduced for many years, but this is really a streamed-down, bipartisan version of this bill to get at the core of what advocates and researchers have found to be the main issue. So the Pact Act would make cancer care planning and coordination a Medicare-covered service, and that's important because when Medicare covers something, it tends to then be picked up by private insurance as well. It would encourage the provider-patient discussions and shared decision-making by allowing folks to bill for that time so that they can say, when we do our cancer care, we do these tests, we do, this examination, and then we take this amount of time to make sure that the patient and provider are on the same page. It's also important for patients who can then take that roadmap to their next provider. Maybe it's their primary care. Maybe it's their eye doctor, whoever it is, that people all know kind of what the course is so everyone can make sure that what they're doing is in line with the cancer care plan. That written plan, or roadmap as we like to call it, explains not just the diagnosis and the treatment, but what are the potential side effects and how do you address those? And those can be physical side effects, but they can also be social emotional side effects. So recognizing what are the potential barriers for folks, but then also what are the strengths and supports they have in their community and their families as well. So it looks really holistically at the person. And then these roadmaps, written plans would be available to patients at diagnosis, at major transition points in care, including survivorship. And that's really important as well. As more and more people are living with cancer, living as cancer survivors, what they're dealing with changes. It evolves over time. If you have children who dealt with cancer when they were younger, how does that affect their health when they're an early adult or as they go to maybe start a family, etc. What are the long-term impacts, and how can we kind of be planning for them and helping people understand what those might be on the front end. And I think that this is really important because, as we heard before, there's much that needs to be done to help empower patients to be engaged in their care, but we need to make sure that when patients are engaged in their care, their providers are there to be part of that. So patients can bring their thoughts, fears, concerns to the provider, but if they feel that they can't take the time to have those conversations, then you're never going to have that that thoughtful discussion that really is what can move this issue forward. So the legislative process is a fun one. A bill becomes a law. You might know the song. Doesn't always work that way, but I'll try and walk through where we are and where we're going. So the bill was reintroduced in June of last year. It's a bipartisan bill, which is really important in this legislative climate. So far, we have 7 bipartisan co-sponsors, and what we need are more. We need to get that number as high as possible because that's the number that shows House leadership that this is an area where we need to move. This is something that people care about. This is something that constituents care about. And that's why you all are so important to help explain to your members of Congress, who a lot of them, frankly, think this is already happening. They're like, oh, of course you would talk and understand what's going on. But the congresswoman has, one of her former colleagues, another congressman, his wife went through cancer treatment, and no one ever talked about the side effects of that treatment. And it wasn't until she was physically going through it that he came to my boss, who's also a nurse, and said, wow, I now understand what it is you guys are trying to do because of what we went through with my wife. So a lot of folks don't know that this matters because it hasn't happened to them. So there are different paths to enactment. This could pass as a standalone bill. That would be ideal and lovely, but again, we need more co-sponsors to get the House committees that are in charge of this type of legislation, Ways and Means and Energy and Commerce, on which my boss sits, and Ways and Means is where Mr. Bustani sits, to take it up, to even move it forward for a vote. It could be merged into a larger package. Again, the best way to get that to happen is to make sure that you have lots of co-sponsors, but also that members, decision-making members in these issues know what's going on. So targeted members like chairmen of certain committees, the House leadership, that sort of thing. So depending upon where you live, your connections might be even more valuable. And then also, CMS is starting to really pay attention to this. They can't necessarily do this on their own, so that's why we have the legislation. But they are starting to adopt the care planning idea in some of the smaller programs that they are working on. So we know that they're doing an oncology care model to encourage transformation in cancer care delivery, and they are requiring oncology practices that participate in that model to provide care planning for all patients. In addition, there's this very complicated, very fun bill called MACRA, but it's pretty much an overhaul of Medicare payment programs for physicians. It is looking at how we put people on an alternative payment model, and this could potentially be included, but that's not going to happen overnight. And what we are looking for is a change that helps every cancer patient, no matter if they're in one of these programs, if their provider is not in one of these programs, no matter what, across the board, so that it's no longer, you don't have to be lucky to be able to have the chance to have real understanding and real say in your care. So the bottom line is we need more support, and that's not just something that I'm going to ask you for. I can also give you a couple ideas of how to do that. So there's different ways to engage with your member of Congress, and I honestly don't know where you all live, but no matter where you live, if you're in the United States, you have one of these ways to engage. So correspondence, as Kristen said, the NCCS has a very easy way to go and send an email about this legislation. It should take 1 or 2 minutes on their website, and that is fantastic. It's important that you send it, but also that your neighbors send it and other people in your community, so that you can show a groundswell of support for this legislation for the congressmen, so that for your congresspersons, so that their staff are like, wow, we have a lot of people who care about this issue. Let's take a deeper look. Let's get on this bill. Phone calls are also wonderful. I know they have some talking points up on their website that you can talk about. Why is PACT important? Why is it important to you? Why would it have been important for your care or your family members' care? Letters, physical letters, they come in, it's good, but because of security measures, it actually takes a really long time for them to ever get to our offices. So it might be easier to use some of the other correspondence methods. Social media is good, talking to your member of Congress on social media, tweeting at them, posting on their Facebook page, and then if you get on their newsletter list, then you'll know what your member is actually talking about, what are they interested in. And if they're not talking about this issue, then you got to ask them to talk about this issue. There are also public events, so those are ways to engage with a member in the community. Sometimes there are town halls in person, sometimes there are town halls on the telephone, where you can ask a question. This is a great question to ask about. What are you doing in this space? Have you looked at the Pact Act? It's really important to us. You can also attend an event where they might be, and you might not be able to corner them and talk about this, but if you can introduce yourself and say that you're going to follow up, they'll know to be looking for that. If you are part of a patient group, you can also invite a member to come join your patient group, see what you all are doing. Some have some way that they are interacting that they can learn about what's going on in your community, just as a community needs to be talking about what is important to them, to the member. And then media. So letters to the editor and op-eds can be very powerful things, but make sure you are giving members a chance to sign on. So that you're doing it in a polite way, but also helping letters to the editor and op-eds can help the community understand that this is really important for our whole community. It's not just for one person, and then you can have that groundswell of interest. And then meetings, of course. And meetings are something that you can do here in D.C. if you come, but more importantly, there are district offices all across the country. I know my boss has 3, so that you're never that far from a district office, and there are staff there whose job is to meet with you. So if you don't have to come all the way to D.C., but you can set up a meeting in your local community and talk to them about why this bill in particular is important for you and why the members should sign on to it, and then follow up with them in a couple weeks to make sure that they realize that this is really a top priority. So with that, I'm happy to take questions. I tried to go very quickly, give you kind of a wide variety of what we're doing. Know that the Congresswoman and her colleague are doing all they can to make sure this is on the radar to move forward. But really what we're finding is people just think that this is kind of the most obvious thing to do, and why is it not being done already, and don't even realize that it's a problem that they need to address. But this bill would help address it. Thank you. I guess I turn it back to Eric.
Actually,
Thank
I'll
you
take
very
it from
much.
there, Adrian.
Oh, go ahead, Kristen.
Thank you very much, Adrian. You brought up some really great points, and I really liked your last line about most members think that this is actually being done, but it isn't. The care planning is not being done to the extent that it should be, and I think that's something that members should be reminded of. And I also want to mention that we do have our Hill Day for the Pact Act coming up next month. It's on Tuesday, June 28th, following our symposium. And I don't know, Adrian, if you wanted to add some comments about our Hill Day visits and when we meet with either staff members or members of Congress to talk about the Pact Act. Is there
Sure. The first thing is don't be nervous. I know it sounds really easy to say that, but before I worked here, I was working in the community, and I remember coming to speak to my elected representative for the first time ever, and it was very, very intimidating. And no matter how much of an expert you think you are on what you're talking about, it can be scary. We are all relatively nice people whose job is to serve you. So please know that when you're meeting with someone, you are their constituent, and that's particularly important if you can meet with the staff or the member for whom you would be voting, because that's when people are like, my boss represents California, and there are lots. California is very large, and some things are good for one area and not for the other. But my boss is always like, well, what about in our district? What's going on in the 24th district? Who's from there? What do they think? So making sure to speak to your member. If you don't get to talk to your member and you can talk to a staff member, that's okay. Our purpose for being here is, members are running from one thing to another. My boss was at a Puerto Rico debt hearing, and then a foreign affairs meeting on Kenya, and then she has a post office that was just on the floor, renaming that was just on the floor, and then she has an HHS hearing later. She's all over the place, right? But she has staff who are have expertise in particular issues. So if you speak to a staff member, that's great. And then I would say to talk about why this is so important, really urge co-sponsorship, and then follow up with that office a week or two later, so that it doesn't just end up on the stack on their desk, because we have many stacks of papers on our desk. But if you follow up, then it repings it for folks that they need to do something with that information.
That's a great point. And we did have one question about our social media for the Pact Act, and we do periodically post on our Facebook page, and there also is the hashtag Pact Act to support the legislation. Eric, do you have any questions in the queue?
We have one question on the phones.
Great.
Okay. One of the things that I can see being asked as you talk to your congressperson about the Pact Act is how, since this is going to be a billable charge, how this is going to impact healthcare costs as a whole, and I can see them thinking that it's going to just layer astronomical costs. So do we have any research, or how do we address that this is a necessary part of the healthcare system that could possibly even lower costs because the patient is informed and in there with the decision making?
Exactly, and that's a really great point. So one of the things, for better or for worse, that we're always dealing with up here is the bottom line of how much does something cost. And I think that many people can speak to their own experience of going to one provider and having a test done and having those results put through, and then you go to another provider 4 days later for something else and they do the same exact test. And that can be considered waste in the system. There's also treatments that people don't want, or certain things that people, if you ask them, what's the vision of your care, these are the options, and they would make a certain decision. Those are all areas where we are paying for things that either are not medically necessary or just uncoordinated. It takes more time out of the patient's day or week to be running around to all different places, and if all the providers and the patient are not all working in the same direction, there's waste there. And so that's a really important point. One of the things that the way that the legislation is specifically drafted is to try to get at that, this is, by this small amount of time and small amount of money, a 20-minute conversation is very different than running thousands and thousands of dollars worth of labs. And so if we can have people all on the same page on the front end, that can really have a great benefit on the back end.
Okay.
That's great. Shelley, you had a question?
Yeah, hi Adrienne. Thank you so much for joining us. My question is, can you talk a little bit about the congressional schedule over the next few months and opportunities in the district? I know I get emails from my member of Congress who has town halls all the time, and then in the summer I think they'll be home even more, so that might be a good chance for people to get to see their members.
Yeah, so that's actually a really great point, and I had it written down, but I just spoke right over it. So the House calendar, it's not a secret. You just have to find it on the Internet. However, I can tell you that in general, there are days where members are in D.C. and voting, and then there are other days when they're back in the districts with their community. And so typically every month there's about 3 weeks where members are here voting and 1 week when they're dedicated to being back in the district. Every member makes their own decisions about exactly when and where they are. I know my boss loves her community and so goes home to Santa Barbara every weekend. That takes a long time, and not a lot of members fly across the country every week, but mine does. But over the summer, there'll be longer blocks of time where members are in their districts. That's an excellent time to have a meeting with the member of Congress, but in your community at their district offices. So, for example, because it's also an election year and there are conventions and that sort of thing, the members should be back in the district for half of July and all of August. So July 18th to September 5th is a time when members will be working in their districts. And so, you might not be able to say, I can come in August 18th, that Thursday at 9:30 a.m., and that's the only time I can do it. But you can say, hey, in August, I can make myself available to have a meeting with my member. Can you let me know when they're available? And the more flexibility you can provide, or again, if you have a patient group, or you own or you work at a clinic or something, and you want to say, I'd love to invite the member to come to our Tuesday night meeting. It's every other Tuesday. Here are the next 5 times that we're going to have it. If they come, they can meet all these members of the community, hear some of our issues. We'd like to thank them for the work that they do. Can they come? That's another way to engage with them in the district. And then again in October, they're scheduled to be in the district all of October, so that's more time as well.
Great, thank you.
I think you can find the House calendar on house.gov, correct?
Yes, it should be there.
All right.
And would somebody call the district scheduler?
I'm sorry?
Would somebody call the district office to try to set up those kind of meetings in the district rather than the DC scheduler?
Sure, you can, but I think that as long as you call your member, if you are talking to the DC person and you say you want to schedule for the district, they'll help facilitate that as well. They might give you the right phone number or the right person to talk to. Just make contact, and we are constantly talking with our district folks, and we send things to them, they send things back to us. So if you're hesitant because you don't know which phone number to call, just call one.
Great.
All right, one question, and I think this, given the time, will be our last question, but a question about the Pact Act and how would the bill and subsequent reimbursement be different for oncology providers billing the visit for care plan delivery for time? I don't know if that answer has actually been worked out in the legislation, but might be part of the implementation.
I'm trying to understand the question better. Maybe I'm just having a mental block because I haven't had any caffeine this afternoon.
That's all right. It is towards the end of the day, and I'm wondering if it's more of a
one of the main issues that providers who say they want to do this type of work find is that whomever they work for says, in a day you need to see X number of patients. You have 6 minutes with each patient. You have 12 minutes with each patient. And that's because that's the amount of time that they are able to reimburse for. So if you have the ability to bill for care planning time, then the provider should be more flexible with their time because it's no longer, quote-unquote, dead time or unbillable hours if you want to get into like the certain consulting and legal fields. So by being able to say, in this amount of time that I spent with a patient, we were doing something the whole time and being reimbursed for that, then that can relieve some of the pressure of getting in, get out, get in, get out.
All right, I think that helps. All right, so we are actually over our 4:30 end time. So now that we are at the end of this webinar, I just want to thank all of our speakers. Adrian, we really appreciate your taking the time. We know you have a crazy schedule.
Of course,
but
no
we
problem
very
at all.
much appreciate the Congresswoman's support and your efforts, so thank you very much. And we appreciate all the webinar participants, very thoughtful questions and comments. And again, I encourage all of you to visit our Cancer Policy and Advocacy Team webpage and to ask your member of Congress to co-sponsor the Pact Act. Thank you again, and we look forward to seeing your evaluations. Now, Eric?
Thank you very much. With that, we will conclude today's webcast. If you take a look at the links box on the left-hand side of the screen, you will see the webcast evaluation. Please take a moment now to complete the evaluation and give us your feedback on this program. And click on Submit when you have completed the evaluation to send us your responses. Your comments and suggestions are very important to us, and they help us to provide you with this kind of quality programming. Thank you for your participation in today's webcast. Today's program is copyright 2016 by the National Coalition for Cancer Survivorship with all rights reserved. This concludes today's program. Thank you. You may now disconnect.